beyond those policies. Policy of professional organization. Each profession has some organization, and there are bylaws and there is constitution of the profession, the organization. We have to follow that. Professional standards of care, fiduciary obligations. And these goals, which I described just now, depend on the nature of the disease, किस stage पे disease है, कितना advanced disease है, what is the nature of the disease, options available, क्या-क्या options हैं हमारे पास, the diagnostic tools क्या-क्या हैं, अगर treatment कर रहे हैं तो treatment में हमारे पास क्या-क्या options हैं, but the preference of the patient, maybe some treatment may be the best in our mind for the patient, but we have to discuss the patient, we have to ask the patient, what does he want? We'll come into the details now. Social, cultural, and economic factors, we have to consider these also. If we divide medical ethics, जो कि आपस में एक दूसरे overlap करते हैं, so we can divide medical ethics in 6 principles. First is beneficence. Beneficence means benefit. You should provide benefit, advantage to the patient, and in the best interest of humanity. Non-maleficence means no harm to the patient. There should not be any harm while treating, while diagnosing, while doing any investigations. There should not be any harm to the patient or the society. Then third comes autonomy. Again, same thing. The patient has right to refuse, accept anything. You have to discuss with him. You have to tell the pros and cons of the treatment, of a diagnosis, or of the disease. And the patient has full right to discuss with you and to decide himself. Then the justice. Treatment should be on the merit of illness. There should be some merit, dignity, izzat, waqar, ana bahut zaruri hai. And it's not only patient, it's of the doctor as well. You have to consider the dignity and of the patient as well as of the doctor. And last but not the least is confidentiality, the trust. Patient should have trust on you. You should have trust on the patient. Then the treatment succeeds. बहुत से डॉक्टर हैं कहते हैं इनके हाथ में शफा है, इनके हाथ में शफा नहीं. If the patient has trust and the doctor has trust on patient, he gets shafa. He will get shafa, inshallah. But trust is the main thing which one has upon another. I'll just go in. This is a talk is long, but I was asked by the host to cut it short due to constraint of time, because so many lectures are followed by me. So I'll cut short. What is beneficence? Well, I'll just give an example that in this case, you don't have to see the ethical values. You see the benefit of the patient. I've given an example. One clear example exists in healthcare where principle of beneficence is given priority over the principle of respect of autonomy. An example, what is example? Example is in the emergency room, patient is incapacitated by the grave nature of accident. He is dying. He is at the verge of death. At that time, we presume that the reasonable person would want to be treated aggressively and we rush to provide beneficent intervention. This is beneficent. This is benefit. In the benefit of the patient, if the patient, at the cost of life, you have to see first the benefit of the patient. So second is non-maleficence. That diagnosis, that investigation, that treatment which you are going to provide him should not harm him. Act in the best interest of patient or research participants. जब रिसर्च करते हैं तो देयर सो मेनी वर्कर्स वी इन्वॉल्व, देयर सो मेनी volunteers will involve. We have to think of their best interest and contribute to the patient welfare, help patients further health interest. इसका नारा क्या है? Slogan is do not harm. Non-maleficence, do not harm the patient. Above all, do not harm, do not harm. Make sure that the procedure does not harm the patient or others in the society. This is the first and foremost thing you have to keep in mind. This principle affirms the need for medical competence. It is clear we should accept that medical mistakes may occur. This principle articulates a fundamental commitment on the part of medical professionals to protect their patients. Now comes autonomy. जो मैंने आपको 6 principles बताए थे, then one of them is autonomy. What do you mean by autonomy? Autonomy includes confidentiality, seeking consent or medical treatment and procedures, disclosing information about their medical condition to patients and maintaining privacy. Privacy should be maintained. तो आगे चलते हैं. So what हम क्या कहते हैं? सर्जरी करते हैं, कोई बात करते हैं. We take just a sign from the patient कि ये form type शुदा है, इसे sign कर दो. This is not enough. Counseling is very important. Counseling is very, very important, and it is the foremost thing in the advanced countries. You should talk to the patient. You should sit with the patient's attendant or the patient and give him the whole scenario of his disease and then discuss the treatment options. And whatever the patient wants, you do that at the end of the day. So informed consent is more than simply getting a patient to sign a written consent form. Informed patient is more important, is a better thing. Process of communication between a patient and physician that results in the patient's agreement to undergo specific medical intervention. Consent उसके साथ discuss करें, time लें, and then reach to a diagnosis के करना क्या है. One of the principles is equity or justice, जैसे मैंने अभी आपको बताया है. Okay, I'll finish in 5 minutes, inshallah. Fair and equal distribution of care, health, resources, and the decision of who gets what treatment. That the burden and benefits of new or experimental treatments must be distributed equally among all groups in society. I am sorry to say कि हमारे यहाँ एक सोसाइटी के लिए ट्रीटमेंट अलग है, एक सोसाइटी के लिए ट्रीटमेंट अलग है. So it's not on paper, it should be practical that the treatment must be distributed equally among all groups of society. Last of the principle is confidentiality. Again, when we are talking to the patient, we are counseling the patient, there are certain issues which the patient doesn't want to be exposed. उनकी बातों को उनको ट्रस्ट में लें कि नहीं, आपकी बातें कॉन्फिडेंशियल रहेंगी, किसी को नहीं बताइए, जिसको आप कहेंगे उसको बताई जाएंगी, उसके अलावा किसी को नहीं बताई जाएंगी. So this is the trust, this is the confidentiality of the patient's information that you have to keep in mind. So obligation of physician to maintain information is strict confidence based on loyalty and trust. जब भी जैसे कि हमने बात की कि ट्रस्ट होगा तो पेशेंट की ट्रीटमेंट भी अच्छी होगी. ट्रस्ट पेशेंट का डॉक्टर पे होना चाहिए, डॉक्टर का पेशेंट पे होना चाहिए. Maintain the confidentiality of all personal, medical and treatment information. Exceptions is failure to release data to appropriate agencies may result in greater societal harm. If needed, it may be given to the law, to the government, to the institution. If it is needed for the safety of society, then it may be given to the agencies. In the realm of healthcare, it is difficult to hold rules or principles that are absolute. इन सब इतनी बातों के बावजूद होता है ऐसा कि द एथिक्स बाज़ औक़ात नहीं प्रिवेल करती है. So even though they are not absolute, they serve as powerful action guides in clinical medicine. अब लास्ट स्लाइड पे आते हैं. व्हाट इज समरी, व्हाट इज टेक होम मैसेज. इतनी जो बातें बताई आपको, इतनी बातें हमने की, अब उसमें समरी, इसका निचोड़ क्या है? निचोड़ ये, मेडिकल प्रोफेशनल्स इंक्रीजिंगली फाइंड देमसेल्व्स कन्फ्रंटेड विथ मोरल क्वेश्चंस एंड एथिकल डायलेमास. ऐसा होता है. वी आर कन्फ्रंटेड. Ethics refers to a professional moral conduct, and I have explained 6 principles of medical ethics, but 4 are very important, and that is autonomy, non-maleficence, beneficence, and justice. With this, I end my talk to thank you all for patient hearing. Thank you very much.
Thank you very much, Professor Anjum, for a wonderful talk, much needed indeed. The next speaker that I would like to invite for the plenary talk is Professor Dr. Nazia Yazdani. Professor Nazia Yazdani is a professor of dentistry and international advisor to Royal College of Physicians and Surgeons, Glasgow. The title of her talk is Quality of Life, Rehabilitation of Orofacial Defects with Implant, Retained, and Conventional Prosthesis. Madam, please. Thank you. I would like to request to the worthy participants to please lower their voices while talking, and it's better if they can switch their mobile off because of the sound disturbances. The speakers are feeling uneasy. Thank you.
Mr. Chairman and panel sitting on the stage, members of the medical fraternity and the dental fraternity, Assalamu alaikum. Oh. Sorry, certain hiccups. Right, okay. So I would like to thank the team and the organizers of this great event. And I'm also feel very privileged and honored that I have been invited here on this August event to share my work and my experiences. I am the only one representing the dental fraternity in this summit. So therefore, my topic is the quality of life and rehabilitation of orofacial defects with implant retained and conventional prosthesis. If you look at this picture, you will find that this is like a geographical representation of people of the world. There are different class, creed, color, shape, form, height, everything seems to be different. But the commonality is that they have got the same facial feature tissues, but they are yet different from one another. This picture by Leonardo da Vinci, this painting, is considered to be the epitome of grace elegance, and beauty. And we all feel very happy and we feel a little more elated when we look at this because this is so well proportioned. And yet, when we look at this picture, we find that why this person has got this form and shape in which he has lost the tissues. But there are some people you will find who will disfigure their faces. They want to make a livelihood, or they want to make an extra money, or they do it for just a passion, as a habit, as a hobby. And we feel that what a contrast and what a difference between the people's attitudes and behaviors when they disfigure themselves or when it is an acquired disfigurement. This young gentleman, he shot himself. He's such a pretty looking guy. He shot himself when he was 22 years of age. And then the mother, who was so unhappy and she was so much in depression that she went to each and every doctor if the son could get the face. Multiple surgical procedures were done for this gentleman, and then a cadaver face was placed on him, and he is still surviving. So what does it all mean? I think Martin Luther King has said it so wisely, that it is the quality and not the longevity of one's life that is more important. But then, what is quality of life? It's the perception of their position in life, in the context of the culture, value systems in which people live, and in relation to their goals, their expectations, standards, and concerns. So I think there are many definitions of quality of life as there are people, because each one is emphasizing what they find is important for them. Therefore, the quality of life we can understand under an umbrella of self-concept. If you look at this picture, what matters most is that how you see yourself. This cat is looking in the mirror, and the reflection that he's getting is as if he is the lord of the jungle. And therefore, when we have this, it is the perception that one's own ability to master or deal effectively with the environment and is affected by the reactions of the others towards any individual. So this quality of life is now considered in the multidimensional concept. And these multidimensional concepts have domains. It is the physical well-being, it is the material well-being, it is the social well-being, it is the emotional well-being, and of course, the development and the activity of the individuals that they are performing. Now, when they have physical well-being is when they are all able-bodied. They have no disfigurement, because the disfigurement trauma, excuse me, अभी तो मैंने स्टार्ट किया 5 मिनट, मुझे तो 20 मिनट दिए थे उन्होंने. This is not even 2 minutes yet. I'm not even halfway through my presentation. So this disfigurement, it lowers your attractiveness scores. And the disfigurement also may lead to unemployment. And when there is unemployment, you become a social recluse. And then, at times, you tend to develop in habits which you usually not when you are not disfigured. and there may be addictions attached to you. You may be having then marital problems, there may be fear, there may be anxiety, they have different behavior changes, and of course, when they become antisocial, they tend to pick up quarrels and fights and brawls, and then they end up in a jail. So this higher incidence may be of alcoholism also, and increased depression as well. So when people have this orofacial disfigurement, it not only impairs their functions, but with it, they also have potential facial disfigurement, they have a social stigma attached to them, and they may be having a psychological trauma. Thus, it just changes the personality of the patient. When you see patients like this, it is very traumatic, even not only for them, but also for the onlookers, because the family and the people around you also get impacted by this disability. Therefore, these lesions, they have a huge burden on the patient's quality of life, on their health, on their socioeconomic well-being, and has an impact on their families, and ultimately it increases the cost of the treatment because they are seeking treatments everywhere. And the big question they ask to themselves is that who are we? What happened? These patients are usually treated by our medical colleagues, like our plastic surgeons and surgeons, who tend to fill them up with their own tissues. But what is not done by them, that is we, as prosthodontists, we do their rehabilitation with artificial substitutes. And there may be intraoral defects, extraoral defects, or there may be a combination of these defects. Looking at this picture, you can see that the patient has got a full dentition in the upper arch, whereas the teeth are missing in this part here with just 2 molars in either side. So this gentleman suffered from a gunshot wound and had lost his lower half, the mandible, which was reconstructed by placing a plate. And as a prosthodontist, I could rehabilitate him with something which was removable to ensure that the patient has his function, aesthetics, and his socially acceptability in the society. This young lady also lost half of her mandible as a result of some diseased process. So she was just, there was nothing here on this side. And this part had to be filled up. The one which was deficient had to be filled up because it was just skin and a little muscle on the other side. So this prosthesis was given to the patient, and she was a very happy customer. This lady, she was given complete dentures in both the upper and the lower arch, and she developed the lesion on the right side in the mandible. So those dentures, the full dentures, they were sectioned, the lower denture was sectioned in half, and 2 implants were placed in there, and the patient was able to eat, masticate, and function properly, despite the fact that she had the lesion which was being looked after by the surgical colleague. This lady, she had no maxilla, and it was very difficult to rehabilitate her. So these dentures were made with the swivel springs on each side, and she also seems to be enjoying her social activity and also her personal activity. This young man, which you had just seen previously, was rehabilitated with an acrylic resin nasal prosthesis, which was attached onto his glasses, and he looks fairly presentable with this prosthesis. This lady also had lost her maxilla and also the nose. She too was rehabilitated with a removable prosthesis, again attached onto the glasses. However, this gentleman, he lost his nose, but he was given a silicone-based prosthesis, which was retained with a biocompatible adhesive. This was a young man who lost his external ear in a road traffic accident, and again a silicone prosthesis attached onto the, with a biocompatible adhesive was given, and he returned back to his job and also to the normal activities. This young boy had a fight with his younger brother, and in doing so, he chewed his external ear, very upset, and he came and he too was rehabilitated with the prosthesis, which completed the external ear. This boy, he was like a baby lying in his mother's lap, who was in the kitchen boiling milk, and just as the luck or his bad luck, he fell into that boiling milk, and he was burnt and lost his external ear. The mother never excused herself for causing so much harm to her own baby, and then she was coming to every person and wanted something more definitive. So these implants were given to the patient, and the ear was retained, and the patient then had to change his hairstyle also, because now he was very confident that he has got his ear. This young lady also, as a result of pathology, her eye was extenerated. She used to wear a black band and glasses on, and then in the process she would also flick her hair so that it would not become more prominent. I gave her this prosthesis, and she would still do the same because that was her habit. He was a tailor who also lost his eye, gave him this prosthesis, and he looks fairly presentable. This man is a teacher. He would not go to work because he thought that his students did not think very good of him because he had no eye, so gave him this one, and he looks fairly good. She is a beautician working in a very high-end salon, and she too lost her eye, gave her this, and in this she also started to wear glasses. And the glasses are given so as you can hide the edges of the prosthesis. But she is really a wonderful person because she works in a beauty salon, and she was about to get married when she got this prosthesis, and she sent me a picture of her wedding day when she was a bride. And how beautifully she has done her makeup. You can't even work it out. So I think the glory goes to her because of her ability of how to do that. This young lady also lost her eye, but implants were given to her, and instead of having the attachment with the glasses or with a biocompatible adhesive, this was directly fixed. Coming to the combination defects, the patient has lost his maxilla and the nose, and so this intraoral prosthesis was given to him, and then this extraoral prosthesis was made, and the patient was fairly happy with it. This gentleman had a small lesion on the nose, and it was diagnosed as squamous cell carcinoma because he was very fond of, according to him, greasing myself and baking in the sun, and this is what he got. And ultimately, there was a huge resection, and the intraoral prosthesis and an extraoral prosthesis was given to the patient, and he was very happy with the outcome. This young man, as a result of some family enmity, they threw acid on him, and he lost this tissue. And he was very distressed because he was a very handsome guy. He showed his picture. So I gave him this prosthesis, and he would wear the glasses and at the same time put the cap on, so that would also hide whatever the defect was, and he thought that gave him a lot more confidence that he could move around and be more sociably acceptable. This man he was a very complex case because there was no maxilla, no nose, no eye. So for him, I had to make 3 prostheses, a denture, an eye prosthesis, and a facial prosthesis. But the ultimate result was very good. This old lady, she came just for the dentures, but she also had some sort of a lesion developing in the maxilla and also in the base of the skull. And then she lost the whole of the maxilla and the nose. But then I requested the surgeon that if I could have something in the maxilla to hold the prosthesis, and so he made the reddish thing, a little sling there, so that I could have some sort of a support to place the denture. So this denture which was made, this part, the interior part, would sit on the patient's lip, and the posterior edge would sit on that sling, and the patient was able to chew and eat. And for a nasal prosthesis, this silicone base was made, and it was given to the patient, who was very happy. And the irony is that when she had developed this great resection, the children, they removed all the mirrors from the wall so that she could not look into that, because she used to feel very distressed. This gentleman had, for no rhyme or reason, he was riding a motorbike, and all of a sudden, high tension wire, they fell on his face and on his lap. He was not electrocuted, but he burnt himself. And the doctors wanted to do multiple procedures, and he never wanted to get those procedures without any covering. So this was the cover which was made for him. And while he wore this face, the surgeons and the doctors were doing debridement and all other procedures to make him look more presentable. This picture, which you had already seen, she was from Gilgit, and she was in the Mayo Hospital, and everybody coming there would look at her, and the family and the people around him, the attendants, they were very upset, that as if she was some alien, and they requested that we could give her some sort of a face, and this face was given to her, and they were very happy that at least this was done. I have been talking about the oral facial defects, but I just wanted to show you another thing. This young girl, she lost her thumb in a kitchen accident, and she was about to get married on the following weekend, and I made her this silicone prosthesis, and when she wore it, this was the prosthesis made for her, and it was given in a different shape so that she could hold any object firmly in hand. So ladies and gentlemen, in conclusion, I can say that this prosthetic rehabilitation instantly improves the quality of life, and the patients are very happy and satisfied with their appearances. They feel much more self-confident and have higher esteem, and of course, they become sociably acceptable. And what is most important is that we need collaboration from you all also when we are working on these such complex cases. So the take-home message is that the quality of life is more important than life itself. Ladies and gentlemen, thank you very much. God bless you all. Pakistan Zindabad.
Thank you, madam, for a really interesting and innovative talk. The next speaker I would like to invite is Professor Dr. Muhammad Iqbal Afridi. Professor Dr. Iqbal Afridi is Meritorious Professor and Distinguished National Professor, Jinnah Sindh Medical University. He is also looking after several offices as a healthcare leader. Currently, he is looking after the Office of Dean, Faculty of Psychiatry, College of Physicians and Surgeons, Pakistan. The title of his talk is How to Achieve Best Health, Well-Being and Performance. So,
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Sadaqallahu al-azim. honorable panelists, worthy delegates, faculties, ladies and gentlemen, and the media people, Assalamu alaikum. My talk would be, and the outline of my talk would be that first I'll talk about what is health and what is mental health and what is well-being and how we can achieve that with good performance. So the domain of concern generally for all people are these things, and is on the top is the body, that is health. So this is the main concern of the person apart from other people. I have seen that people during their career focus, especially doctors community, just on the credential rather than on their ignoring their health. خاص طور پر جو ہمارے physician ہیں including me, most of them they are indulging in the patient care at the cost of their health. So I think we should also take care of ourselves. So coming to the WHO definition that health is not merely the absence of a disease, but it's complete physical, psychological and social well-being. اب واٹ آر دی کمپوننٹ، لیکن میں اردو میں تھوڑی بات کروں گا تو زیادہ اچھا ہے کہ صحت محض کسی بیماری کی عدم موجودگی کا نام نہیں، بلکہ یہ جسمانی، نفسیاتی اور سماجی آسودگی یعنی خوشحالی کا نام ہے. اب یہ ہے کہ واٹ آر دی یارڈ اسٹک آف فزیکل ہیلتھ. جیسے میڈم نے تھوڑا بتایا کوالٹی آف لائف فگر، تو سب سے پہلے فزیکل کے 3 یارڈ اسٹکس ہیں: اناٹمی، فزیولوجی اینڈ بائیو کیمسٹری. سوشل کے جو ہے وہ بھی 3 کمپوننٹ ہیں. دا پرسن شوڈ بی فٹ ان دا فیملی، ان دا کمیونٹی ویئر ہی از ریزائڈنگ اینڈ دی آرگنائزیشن ویئر ہی از اسٹڈنگ اور ورکنگ. یہ تینوں جگہ پہ فٹ ہونا چاہیے. اینڈ کمنگ ٹو دی مینٹل ہیلتھ، ABC ٹھیک ہونی چاہیے. A سے افیکٹ جس کا مطلب ہے جذبات، B سے بیہیویئر رویہ، C سے کوگنیشن جس کی اردو ہے وقوف. وقوف کیا ہے؟ فہم، سمجھ جو ہے وہ ہے. اب اگر ہم دیکھیں اب ہیلتھ کے حساب سے ہمیں پولیٹیشین نے بتایا کہ روٹی، کپڑا اور مکان. تو اگر معاشروں کا آپ یہ ماڈل دیکھیں اس میں فزیولوجیکل نیڈ دیز آر اسینشیل، اس کے بغیر ہم کچھ نہیں ہیں. اور جب تک وہ روٹی، کپڑا اور مکان کے ساتھ بجلی، پانی یہ چیزیں نہیں ہوں گی تو ہم اس کے بعد میں سیفٹی نیڈ پہ جاتے ہیں، اور اس کے بعد بلونگنگ نیڈ کہ مجھے کوئی چاہے، میں کسی کو چاہوں، اور اس کے بعد میں اسٹیم نیڈز ہیں، اور پھر جو ہے سیلف ایکچولائزیشن ہے کہ یو آر ان گیونگ پوزیشن رادر دین گیننگ پوزیشن. تو لہٰذا ہم آگے ترقی نہیں کر کہتے ہیں کہ جب تک یہ بیسک نیڈ پوری نہیں ہوں گی تو اس میں تخلیقی یا انوویشن نہیں آئے گی. اب یہ سلائیڈ میں نے خود بنائی ہے بڑے احتیاط سے. اکثر ہمارے ہاں ہوتا ہے کہ پریونشن از بیٹر دین کیور. یس اٹ از بیٹر بٹ اٹس ناٹ دا بیسٹ. ہمارے یہاں ہوتا ہے بچے کو فیل نہیں ہونا چاہیے. اگر فیل نہیں ہوا، پاس ہوا، 33 نمبر لے لیے تو کیا کمال دکھایا. تو لہٰذا صرف پاس ہی نہیں ہونا ہے بلکہ پاس ہونے کی اعلیٰ مقام پہ جانا ہے. سملرلی اگر آپ اس سلائیڈ کو دیکھیں کہ ایک تو نیچے کی طرف جو ہے سائن آف النس، دین کرونک النس، دین پھر اٹل نقصان جو ارریپیئریبل ہوگا. اس کی مثال ایسے دوں گا، اگر اوپر سے ایک بوند نیچے گرے گی، اگر ہم نے کچھ دن میں یہ ریپیئر نہیں کیا، 6 مہینے بعد اتنا کھڈا ہوگا کہ یہ اس کو پھر آپ پانی روک بھی دے نہیں ہوگا. اسی طرح سے اگر آپ کے گاڑی کے ٹائر جو ہے وہ امبیلنس ہیں اور کچھ 6 مہینے بعد اتنے گھس چکے ہوں گے کہ آپ بیلنس بھی کر دیں بیکار ہے. تو دیر فور ہمیں جو ہے اس طرف جانا ہے کہ روک تھام پریونشن سے کیا ہے؟ فیئر ہیلتھ، بیٹر ہیلتھ اینڈ بیسٹ ہیلتھ. صحت کی معراج. صحت کی معراج کیا ہے؟ یوٹیلائزنگ آل یور باڈی، آل دی فیکلٹی آف یور مائنڈ. جس میں آپ دیکھیں نا، میں ایک عالم سے ملا، مجھے خود 6 زبانیں آتی ہیں سندھی اور پشتو ملا کے، کہ ایک عالم سے ملا 75 زبانیں آتی تھی. ایک پورا قرآن شریف دوسری زبانوں میں حفظ کر لیتا ہے. اٹ مینس وی ہیو دی کیپیسٹی ان یور مائنڈ اینڈ باڈی. تو لہٰذا ہم تندرستی، عافیت، آپٹیمل ہیلتھ پہ کیسے پہنچیں اس پہ ہم آگے بات کریں گے. اب میں خاص طور پر اس موقع کو سب سے پہلے تو میں اس بات پہ بھی شکر گزار ہوں پروفیسر معین کا کہ انہوں نے یہ آرگنائز کیا اور یہ موقع دیا مجھے کہ میں مینٹل ہیلتھ پہ بات کروں. ذہنی صحت کو جب WHO کو لے کے آ گیا کہ اس کو ڈیفائن کرو, they were not able to define. After few weeks they just came with one sentence کہ health is broader than lack of illness, lack of mental illness. یعنی ذہنی صحت ذہنی بیماری کی عدم موجودگی سے کہیں بڑھ کر ہے. کیا بڑھ کر ہے, ناپیں کیسے؟ لیکن لکیلی ورلڈ فیڈریشن آف مینٹل ہیلتھ نے ایک جامع قسم کی ڈیفینیشن بنائی ہے کہ صحت, ذہنی صحت ایسی کیفیت کا نام ہے جس میں انسان کو اپنی صلاحیتوں کا اندازہ ہو کہ مجھ میں خامیاں کیا ہیں, اچھائیاں کیا ہیں. خامیاں ہیں اس پہ قابو پاؤں اور اچھائیوں کو اجاگر کروں. اچھا یہاں ہم بڑی غلطی کرتے ہیں, یہاں فیمیل بیٹھی ہیں, ہمارے یہاں اگر بچہ فیل ہوتا ہے میتھس میں تو میتھس کے پیچھے پڑیں گے اور نیچرل ٹیلنٹ کو بالکل بھول جائیں گے. اس کی مثال ایسی ہے کہ اگر میں وقار یونس سے بیٹسمین بنانے پہ زور لگاؤں نہیں لگے گا, جب تک اس کی نیچرل ٹیلنٹ کو ضرور ہمیں اجاگر کرنا چاہیے. اور دوسرا اس کے ساتھ روز مسائل سے نمبر آزما ہونے کی صلاحیت رکھتا ہو. نمبر 3, یہ جو اردو غلط کی گئی ہے, مفید اور ثمرمند کام کرے, فروٹفل کام کرے اور اپنی صلاحیتوں کو بروئے کار لاتے ہوئے معاشرے میں ایک فعال کردار ادا کرے. If somebody is not contributing to his or her community and organization, he is not healthy. ہمارے یہاں کیا, بچہ پڑھ لو, ڈگری لو, باہر جاؤ. ارے بھائی, if he or she is not serving, he or she may be king or queen in the other country, but if she or he is not contributing to the community, family, country, he is not healthy. تو therefore اس کسوٹی کو اگر ہم اپنے آپ پر اپلائی کریں تو بہت سارے ہم میں سے یہ پورا نہیں کر پائیں گے. اب ہم آتے ہیں ویل بینگ پہ. There are 8 dimension of health, well being. اب 8 dimension میں باقی تو آپ سب کو پتہ ہے کہ ایموشنل, فائنینشیل, لیکن میں یہ کہنا چاہتا ہوں کہ جو اسپریچول ہیلتھ ہے, اسپریچول ہیلتھ پہ آپ کی فوکس چاہتا ہوں. اسپریچول ہیلتھ پہ میں آپ کی فوکس چاہتا ہوں کہ ہمارے جو پولیٹیشین ہیں ان کی یہ نہایت کمزور ہے. پرپز اینڈ میننگ آف لائف کیا ہے؟ صرف پیسے جمع کر کے وہ کر کے سوئس اکاؤنٹ میں رکھیں, کھائیں گے کب؟ اس وقت گوشت ہوگا, دانت نہیں ہوں گے. لیکن اس سے کہیں زیادہ ہم لوگ کی انٹلیکچوئل ہیلتھ خراب ہے ہم لوگوں کی, کہ ہم نے چنا کیوں ہے دی ایبلٹی ٹو تھنک کلیئرلی اینڈ رسپانسبل ڈیسیشن کے ووٹ دیتے ہوئے اول تو جائیں گے نہیں, جائیں گے تو غلط بندے کو دیں گے. تو لہٰذا ان کا قصور تو ہے ہی ہے, ہمارا بھی قصور ہے کہ ہم نے ایسے, ابھی کراچی میں جو بلدیاتی انتخابات ہوئے 18% لوگوں نے حصہ لیا, باقی انہوں نے سوتے میں گزارا. تو لہٰذا ہم اب ان چیزوں کو کیسے اچیو کریں؟ اب مغرب نے سارا ڈنڈورا پیٹ لیا کہ ہر چیز کو مائنڈ فل ہو کے کریں. اب مائنڈ فلنس کیا ہے؟ اٹینشن, انٹینشن, ایٹیٹیوڈ. ایک ریسرچ کی گئی کہ اگر آپ برتن بھی دھوئیں مائنڈ فل ہو کے تو 38% ڈپریشن کم ہو جائے گا. اب وہ کیا ہے کہ یہ میں ابھی اس پہ مجھے یاد آیا کہ یہ جب کورونا تھا تو WHO کے سیکریٹری جنرل نے غلط ہاتھ دھوئے. میں اس وقت روزہ بھی تھا, وہ ہاتھ دھوئے جا رہا تھا, پانی بہایا جا رہا تھا. تو ہم نے ایک 15 پوائنٹ کا اردو میں بنایا, انٹرنیٹ پہ ڈال دیا ہے کہ سب سے پہلے نیت کریں کہ میں یہ ہاتھ جو دھو رہا ہوں صفائی نصف ایمان ہے, اور اس کے ساتھ ساتھ اسراف کے تقاضوں کو مد نظر رکھتے ہوئے ہاتھ دھوؤں گا, پانی نہیں بہاؤں گا. یہ نہیں کہ 22 کروڑ عوام جب 30-40 سیکنڈ پانی بہائے گے تو نکاسی تباہ برباد ہو جائے گی, پانی کم پڑ جائے گا. تو اسی لحاظ سے ہمیں جو ہے اگر برتن بھی دھو رہے ہیں, اسٹڈی بھی کر رہے ہیں کہ یہ ورک از ورشپ, ورک از تھیراپی. اس کو بلیسنگ سمجھے, پڑھانے کو, پڑھنے کو, سیکھنے کو کنسیڈر جیسے مہمان از بلیسنگ, سملرلی پڑھائی, پڑھنا, کام, ورک از ورشپ, ورک از تھیراپی. تو لہٰذا ہر چیز مائنڈ فل ہو کے کریں, اور یہ پہلے سے ہی تھا خشوع وضو کے ساتھ ہر کام کریں. اچھا اب ہم دیکھتے ہیں کہ سارا کچھ اس پہ جا رہا ہے آئی کیو. نو, the research has proved کہ EQ emotional quotient is more important than IQ. اس کی مثال میں دوں گا کہ اگر آپ ایک گروپ میں فٹ نہیں ہیں, مطلب بیٹنگ کر رہے ہیں اور آپ بہترین بیٹنگ کر رہے ہیں, اچھا دوڑتے ہیں, سامنے والا کے ساتھ کمپیٹیبلٹی نہیں ہے, وہ آپ کو آؤٹ کر دے گا. تو therefore ہمیں چاہیے کہ ہم گروپ میں رہنا سیکھیں, اور اس کے لیے انڈیکیٹر آف سیلف مینجمنٹ کیا ہے کہ پرسنل گروتھ, پروفیشنل گروتھ. اچھا یہ بھی ہے کہ ہم بعض اوقات یہ اسٹوڈنٹس لائف میں, میڈیکل کالجوں کی لائف ہے تو مجھے بڑی تکلیف ہوتی ہے کہ کس طریقے سے وہ ہمیں جب پہلے ڈسیکشن ہال میں بھیجا گیا تو فارملین کی جو تھی اس سے ہی آنکھیں خراب ہو رہی تھیں. تو پرسنل گروتھ, پروفیشنل گروتھ اور جو ہے ریلیشن شپ, سارا اس عمر میں جو ہمارے زیادہ تر بچوں کی, نوجوانوں کی انرجی اس پہ خرچ ہوتی ہے کہ شادی کمپیٹیبلٹی کیسے ہو. حضرت خدیجۃ الکبریٰ نے خود حضور, شی واز 40 اینڈ حضور صلی اللہ علیہ وسلم 25, خود پیغام بھیجا, اور ہمارے ہاں ان کو حقوق حاصل نہیں ہیں. تو لہٰذا ہمیں یہ چاہیے کہ, چونکہ مجھے کہا گیا کہ ذرا کم مختصر کریں تو میں ذرا کچھ سلائڈیں, لیکن انٹیگریٹی کو ذریعہ بحال رکھنے کی کوشش کریں, اور اس کے لیے ضروری ہے کہ ہم اپنی پرائرٹیز طے کریں. پرائرٹی کیا ہے, ہماری ترجیحات کیا ہے؟ سب سے پہلی ترجیح ہمارے ایمان ہے, پھر صحت ہے, پھر عزت ہے, پھر خوشی ہے, پھر ڈگریاں, کریڈینشل ہیں, اور پھر یہ جائیدادیں یہ ہیں. اب میں اس پہ یہ ہیپینس پہ بتایا, جاپان اس میں سنگاپور میں سارا سسٹم آف ایجوکیشن چینج کر دیا کہ دا اسٹوڈنٹ شوڈ لرن ہاؤ ٹو ریمین ہیپی, خوش کیسے رہیں. ہائی مارکس از ناٹ کرائٹیریا آف سکسیس, یہ پروو ہو گیا ہے. میں اپنی کلاس میں دیکھتا ہوں کہ میری کلاس میں زیادہ تر 20 گریڈ سے اوپر نہیں گئے, اور میں 22 گریڈ میں 2 بار, دوسری بار مجھے بنایا اللہ کے فضل سے. تو لہٰذا اس طرح سے پرائرٹی بنانی چاہیے. اسٹوڈنٹس کے لیے میری گزارش ہے کہ صرف ڈگری نہیں, باقی بھی چیزیں ہیں اس کو ذہن میں رکھیں, اور اس کے لیے جیسے یہ تو خیر پیشے کے اعتبار سے بتائی گئی چیزیں, میں اس کو ریپیٹ نہیں کروں گا, لیکن پروفیشنلزم آپ کے اندر ہوں. ڈاکٹروں کے لیے اور سب کے لیے ضروری ہے کہ نالج, اسکل اور ایٹیٹیوڈ ٹھیک ہو. اور دوسری بات, آج کل جو ہے صحت کی بات ہو رہی ہے, سب ہم ٹیکنو اسپیشیز ہو گئے ہیں, ایوری بڈی از ان دی موبائل فون, اور اس کی کندھے, اب میرا خیال ہے بچے جب آئیں گے تو گردن ٹیڑھی ہوگی اس کی, کیونکہ وہ ماں کے پیٹ سے جو ہے وہ سنتا ہوا آئے گا. تو لہٰذا وی آر ٹیکنو اسپیشیز, اور ادھر بیٹھے ہوں گے کھانے پہ اور چیٹنگ ہو رہی ہوگی. تو لہٰذا اس چیز, اور یہ جب دیکھا گیا پچھلے 1 سال میں کہ 1 منٹ میں لوگ کیا کیا کر رہے تھے, ملین لوگ لگے ہوئے ہیں چیٹنگ پہ, کوئی کدھر. تو یہ ایک خطرناک چیز ہے وچ از ناٹ ہیلدی, اور کہتے ہیں ہر چیز میانہ روی ہو. اب ان چیزوں کو ہم امپروو کیسے کر سکتے ہیں؟ ان چیزوں کو ہم امپروو ایسے کر سکتے ہیں کہ اگر ہم چاہیں کہ اپنی ہیلتھ کو پروموٹ کریں, ذہنی صحت کا فروغ کریں اور بیماریوں سے بچیں, تو انفرادی طور پر میں کیا کروں, اپنی ABCD کروں, A سے F. اور علامہ اقبال نے کیا خوب کہا تھا, یقین محکم, عمل پہم, محبت. یہ 3 چیزیں ہوں گی. یقین محکم کیا ہے, آپ کی کوگنیشن, فہم. عمل پہم, بیہیویئر, مسلسل. اور محبت, دیٹس ایفیکٹ, ایموشن. ان کو کریں تو زندگی کی یہ جو ہے کامیابی ہوگی. دوسرا یہ کہ آدھا ایمان تو پاکی پہ ہے, وہ ہم نے بھنگیوں کے لیے چھوڑا ہے. اس کے بعد میں 50%, 100 نمبر کا پیپر تھا, 50% بھنگیوں کے لیے چھوڑا. اس کے بعد میں ہم نے حقوق العباد, وہ ہم نے انگریزوں کے لیے چھوڑا, 25-30% وہ بھی ہے. پھر اس کے بعد میں ورک از ورشپ, حصول رزق حلال عبادت, وہ ہم نے جیپنیز اور چائنیز کے لیے چھوڑ دیا. تو 90% ہم پیپر اٹیمپٹ نہیں کرتے اور سوچتے ہیں ہم پاس ہو جائیں گے. کیسے پاس ہوں گے؟ تو لہٰذا ہمیں چاہیے کہ اپنی اچھی طرز زندگی, وقت پہ سونا, اٹھنا, ورزش, عبادت, یہ سب کی اہمیت ہے. اور ساتھ ساتھ نشے سے دوری اور ارریشنل یوٹیلائزیشن آف موبائل ختم کریں, اور اجتماعی طور پر باہمی تعلقات اور رویوں کو ٹھیک کریں. ساس بہو کا, سینئر جونیئر کا, استاد شاگرد کا, پڑوسیوں کا, اگر ہم تو جھگڑے ہی نہیں ہوں گے, تو عدالت کے, کورٹ کے کام کم پڑ جائیں گے. اب ہم پہلی بات پہ کرتے ہیں کہ اپنی سوچ کیسے, کوگنیشن کو کیسے ٹھیک کریں. کوگنیشن کی اردو وقوف ہے, جو بے وقوف سے بے ہٹا دو, جو بچے وقوف ہے. اب اس کو ہم کیسے کریں؟ ہمارے یہاں کہتے ہیں ہماری چیزیں ایسی نہیں ہیں, ہمارا ملک اچھا نہیں. بھئی یہ چائنیز ورژن ہے کہ if one can do it, you can do it. If some can do it, you can do it better. If none can do it, you must do it. اور ہمارے یہاں کیا ہے, if one can do it, let him do it. If some can do it, no need to do it. If none can do it, how can you do it? تو اس چیز کو ہمیں چینج کرنا پڑے گا کہ we can do it. اور اس کے لیے 5 pillars of health ہیں, جس میں آپ کی ڈائٹ ہے, متوازن غذا, اس کے علاوہ جو ہے اچھی سلیپ, اللہ کی بہترین نعمت ہے. میں نے اس پہ ایڈیٹور لکھا ہے جنا ہاسپٹل کی, ہمارے جو جرنل ہے اس میں. اور ایکسرسائز, حرکت میں برکت ہے, اسے انڈورفین, انکیفلین, BDNF ریلیز ہوتے ہیں. BDNF کیا ہے؟ برین ڈیرائیو نیوروٹرافک فیکٹر, which are useful for prevention of depression and dementia. اب اس کے لیے ہمیں چاہیے کہ ہر چیز میں گریٹر گڈ کو دیکھیں, فوکس کریں ہر چیز پہ اور ریزیلینس پیدا کریں. اور جو جیسے کہ ہم نے پہلے بتا دیا کہ ایکسرسائز اور ویٹ کو کنٹرول کرنا اس ساری بیماریوں کو روکے گا. یہ میری اگلی کتاب آ رہی ہے, تیسری کتاب, جس میں یہ ایک میں بنایا ہے کہ 9:30 بجے میلاٹونین کام شروع کرتا ہے اور 7:30 بجے صبح تک, اس دوران میں 8 گھنٹے کی نیند بہترین ہے. 1 hour is equal to 2 hours, اور اگر اس کے بعد سوئیں گے تو یوزلیس ہے. تو اس کے لیے ایک نیوٹریشن کے حساب سے یہ جو فضول چیزیں جو ایڈورٹیزمنٹ ہے اس کے بجائے ہیلدی فوڈ کھائیں. اور ایکسرسائز کے بہت فائدے ہیں, جس میں سے یہ کچھ فائدے جو ملٹی ٹاسکنگ بیہیویئر. اگر اسٹوڈنٹ چاہتے ہیں, میری مرضی ہوتی تو امتحان سے پہلے ان کو 5 منٹ دوڑاتا کہ وہ جو ہے اس کی جو ہے صحیح ہو جائے اور صحیح جگہ پک کرے کہ کہاں پہ آپ نے مارک کرنا ہے. اور دیز آر دی ویریس میتھڈ آف ریلیکسیشنس. سسٹینیبل گول کین ناٹ بی اچیو وداؤٹ دی کمپوننٹ آف بیہیویئر اینڈ مینٹل ہیلتھ. چاہے ہر کمپوننٹ کے ساتھ ہماری یہ وابستہ ہے, اینڈ وی ہیو ٹو پروو دیٹ ہیلدی باڈی, ہیلدی مائنڈ, ہیپی ہیومن. اور the mental health is the cornerstone of health. اب how can we achieve this? یہ سلائڈ جب میں نے سری لنکا میں لگائی, I was as a president of Pakistan Psychiatric Society, کہ what is investment? Investing in mental. تو امریکن کھڑا ہوا کہ ہمارے ملک میں تو ہم نے بڑے پیسے لگائے ہیں, کچھ رزلٹ نہیں آ رہا. میں نے کہا آپ کا خیال ہے کہ پیسے, انویسٹمنٹ صرف پیسے؟ نو, انویسٹمنٹ انٹینشن, نیت, اٹینشن, ایٹیٹیوڈ, ٹائم, انرجی, ریسورسز, ایڈوکیسی. مثلا ایک بار جو ہے اس کی ایڈوکیسی کریں تو بہت سارے مسئلے مسائل حل ہو سکتے ہیں. اور اب اس سلسلے میں یہ عرض کرنا چاہتا ہوں کہ ہمیں یہ گرانٹ تو نہیں ملا کینیڈا کی طرف سے, لیکن ہم نے ایک سلسلہ شروع کیا ہے میڈیکل کالج میں, جس میں اسٹوڈنٹ ویل بینگ پروجیکٹ ہم نے شروع کر دیا. 7 میڈیکل کالج میں ہم نے اٹیچ کر دیے انیشل فیز میں, اینڈ وی ول ٹیچ دا فیکلٹی دیٹ دے کنسیڈر ٹیچنگ ایز اے بلیسنگ, انجوائبل ایکٹیویٹی. اور اسٹوڈنٹس کو کہ لرننگ شوڈ بی تھرو فن رادر دین فیئر اینڈ برڈن. اور اس کے لیے میں بس آخری ایک سلائیڈ ہے کہ یہ اب پوری دنیا کا اس بار کا سلوگن تھا کہ میکنگ مینٹل ہیلتھ اینڈ ویل بینگ اے گلوبل پرائرٹی. ذہنی صحت اور خوشحالی کو, تندرستی کو سب کے لیے عالمی ترجیح بنائیں. اور ایک ہم اپنا جنرل بھی چلاتے ہیں جو ہر جگہ سے وہ ہے. میں اس کا اختتام کرتا ہوں اپنے شاہ لطیف کی جو ایک امن کی دھرتی کے سندھ کی, کہ سپت بھریا سپنی کپت کی نہ کرو, تھورے گھنے ڈींहं میں ماण्हू वञणु मरियो, तेसीं कुर्ब कयो जेसीं जीअ रहियो जहां में. थैंक यू वेरी मच. اور یہ جو ہے سلائیڈ یہ ایک دکھا دیں, مائنڈ اور دل کو بیلنس رکھنا. یہ سلائیڈ جو ہے یہ اس کو بیلنس رکھنا ہے. اگر آپ نے دل کی بات زیادہ مانی وہ بھی ٹھیک نہیں ہے, اور نہ دماغ کی بات مانی, درمیان میں رکھیں. تھینک یو.
Ladies and gentlemen, first of all, thank you, Professor Iqbal Saab, for such a nice lecture. And ladies and gentlemen, we have 2 speakers who need to fly urgently to somewhere. And that is why we are moving forward for a souvenir distribution ceremony. However, we have 5 plenary talks left, so the session will be continued. For honoring our guests with the with a certificate and souvenir from the summit, I would request Professor Abdul Sattar Memon Saab to please come forward. And I request first Professor Iqbal Afridi to please receive his shield and certificate. So. Next, I would request Professor Dr. Nazia Yazdani to please come up on the stage and receive her shield. Thank you, ma'am. Thank you, sir. Sir, thank you. Moving forward for the next talk, uh, I would request Professor Dr. Azizunisa Abbasi. Professor Dr. Azizunisa Abbasi is Professor of Gynecology and Obstetrics. She has come to Jamshoro all the way from the Ahmedabad, and she is also looking after the Office of President, Society of Gynecology and Obstetricians, Pakistan. The title of her talk is Triple Mortality, part of SDG 3 and 4.
Bismillahirrahmanirrahim. Many thanks to Jamshoro University Administration and Organization for inviting me. I'm really grateful and really feel honored to be part of this great activity. A few words about my organization. SUGP Pakistan is a huge society of obstetrician and gynecologists. We have 4,000 to 5,000 around life members, and there are 28 sub-chapters all over Pakistan. Today I'm going to talk about triple mortality, which is part of Millennium and Sustainable Development Goals 3 and 4. MGDs and SGDs 3 and 4 is related to maternal and child health. And triple mortality is MMR, maternal mortality, PNMR is perinatal mortality, and IMR is infant mortality. And these health parameters are very poor in Pakistan, and despite of having so many FCPS and qualified gynecologists all over Pakistan, we are not getting down on these parameters. Infant mortality, perinatal mortality, maternal mortality, sadly, Pakistan is topping the world in these three health parameters. And even in South Asia, these three health indicators are very poor in Pakistan. So, this is comparison of 2020 and 2010 statistics. In 2010, we had maternal mortality 276, and now in 2020, we have an 86. But this recent survey is door-to-door survey, and there is always underestimation of the maternal deaths. And in practice, due to population explosion, maternal mortality is rising, not on the decline. Perinatal mortality, it was 100 to 110 per thousand in 2010, and now it has been reduced to 60 to 90. And neonatal mortality rate 40 now, and it was 54 before, and infant mortality was 54 now and 60 before. But a way to go. Still these indicators, health indicators, and mortality is still very high. Pakistan got enrolled in Millennium Development Goal, and we needed to achieve that goals in 2015, and we lagged behind. We couldn't achieve anything from MGDs. Now Pakistan is enrolled for SGD, Sustainable Development Goal, and let's see what we can achieve by 2030. Major causes of maternal mortality in Pakistan, 80% in experience are PPH, hemorrhage, and eclampsia. And both of these diseases are 100% preventable. Nobody should die of PPH, no woman should die of eclampsia. Other causes are less common, obstructed labor, anesthesia problems, and all that. And recently, SUGP is in collaboration with FIGO, Melinda Gates Project, and we have chosen two specialties, these causes, major PPH and eclampsia. And we will be doing from the society level, we'll be doing training, emergency training in the peripheries of Pakistan, because in the big cities, everybody is there teaching hospitals, and we get There's death from the periphery, rural areas. 80% of the dead, half dead and dead bodies we get from the periphery. Once a patient reaches a tertiary care hospital, if she is in reasonable condition, she can be saved. So we need to address the periphery of rural areas of Pakistan. This is very important slide, and this shows education-wise MMR, maternal deaths, and 64% around ladies, they were uneducated. Even primary, secondary, 10th grade education made a lot in preventing maternal deaths. So uneducated, 80% of the women are uneducated, and MMR is more common in uneducated. So we need to do advocacy on the women education. Perinatal mortality mean intrauterine death and deaths within first week of life. Again, Pakistan is having PNMR very high level, and most of these problems, I think, are iatrogenic, misuse of misoprostol, induction and augmentation of labor unnecessarily, leading to perinatal deaths. We need to address these things. In the next slides, I will show how we are going to tackle these problems. Neonatal mortality, 40 per 1,000, it's quite high. 1,000 babies deliver 40, we can lose them. Many causes are there. Mostly preterm infections, birth asphyxia, and meconium aspiration, respiratory distress syndrome, congenital anomalies, and again congenital anomalies, common ones are neural tube defects, which are 100% preventable if we give folic acid to patient in pre-pregnancy and level and 3 months during first pregnancy. We can decrease the incidence of congenital anomalies, especially neural tube defects. Infant mortality, the recent figures are 54 per 1,000 live births. There is a slight decline from the previous years, but still we need to do a lot to prevent these precious lives. Infant mortality, again, it's quite high. Because of time constraint, I will try to finish it quickly. So main causes of infant mortality are pneumonia, gastroenteritis, again 80%, and other diseases. And we can prevent these deaths by advocating breastfeeding and early intervention if the babies get diarrhea and pneumonia. And this is the comparison of MGDs. 2010 and 2015. There is a slight decrease in all the parameters, but again, we need to do a lot to reach the Sustainable Development Goal by year 2030. What are the strategies? How can we reduce this triple mortality? And for MMR, the target provided is reduce MMR to 70 per 100,000 by year 20. The target is very difficult to achieve, but it can be achievable by sheer hard work. How can we tackle this problem? National and provincial government, and I don't think, people say talk to the government, I don't think a government can help a lot in this matter. We need to work individually, we need to work on our own. Governments have their own problems, and they are not even interested in these parameters. We need to do advocacy of the girl education, breastfeeding, and child nutrition. Girls' education is very important. We need to invest in girl education, because we have seen that uneducated women, 80% they die of childbirth problems, and education is very important to prevent MMR at least. We need to do training of health workers, and we need to do EMOC training, emergency obstetrics and gynae. And now from the SGP forum, we are planning to do refresher courses and EMOC training programs for personnel working in the rural areas and periphery, especially the midwives and lady health workers and nurses and doctors who deal with the pregnant patients. We need to tell them how to give first aid to any obstetrical emergency if it arises. Very important public awareness program. People should know what is the disease and where to go in case of emergency. Because one of the problem in gynae office, which I told you, that second most common cause of maternal mortality is eclampsia. And eclampsia is the fits in pregnancy. They are epileptic-like fits. And most of the people, because of lack of awareness, they think there is a gin or something else, and they go here and there and don't take proper advice. So public awareness programs are very important. And second thing is supplies of the life-saving drugs, magnesium sulfate, tranexamic acid, misoprostol, and balloon tamponade. These are very cheap drugs, and usually if we do survey today, none of the emergency trolley in any labor ward has all these life-saving drugs. So from SOGP Forum, we will generate funds and we will buy these supplies, and we will regularly supply these medication, life-saving drugs to the periphery where ladies deliver. Family planning is very important. 2/3 of the maternal deaths, the previous survey showed that they died, death MMR was more common in multiparous and grand multiparous patients. So if we avoid multiparity and grand multiparity with proper family planning methods, so that is another tool to reduce the maternal mortality. Contraceptives, methods, training, ample supply of contraceptives, these are not available anywhere. All over Pakistan, the situation is the same. So we need to work. These babies, these all belong to single mother. So we need to have at least birth spacing for 2 years. And if there is 2 years birth spacing, a woman cannot have these many babies. Because all the problems of pregnancy and delivery and postnatal, they arise more common in multiples and grand multiples. These are the grannies, I say grand multiples, these are very dangerous patients. They usually die of complications. Then we need to do birth spacing, training of the family planning staff, free and ample supply of contraceptive, especially in the rural areas. Rural health programs, midwifery training is very important, and first aid for obstetrical emergencies. It's very easy to give, and it's very easy to save the maternal life before referral of any obstetrical emergency or any critical patient. Nutritional deficiency and MMR, most of the 80% of the Pakistani women in pregnancy, especially last trimester of pregnancy, they are anemic. So anemia, no patient should go into labor if HB is, this is the WHO slogan, the no patient should go into labor if HB is less than 10. So we need to address in antenatal period, supplements of iron, every woman should get a tablet of iron in pregnancy. A woman should get extra milk, extra diet, eggs to prevent anemia in pregnancy. This we can only do by doing antenatal clinics. Antenatal clinics mean talking to the antenatal patients. And then education, equal rights for both girls and boys. Especially in Pakistan, we prefer boys over girls, and girls are our asset. Please do invest in girls. Advocacy for girls' education. I will said that all the complications of pregnancy and related issues are directly inversely proportional to the education of the woman. So we need to advocate from our forum, not from the government level. Government is working on their own, but we should, the physicians, the doctors, and the gynecologists and pediatricians, we should do advocacy for girls' education. Reproductive health education of the teenage girls. We have started in my area, Aptabad, we have started doing this reproductive health classes in class 9th, 10th, and 11th and 12th. And we need to tell them how to go forward for many problems associated with teenage girls. So we talk of women empowerment. Women empowerment will come from good education, stable jobs, and financial stability. And education is birthright of every child. And then malnutrition, infant and child malnutrition of the babies, newborn babies and infants in childhood, it starts from the intrauterine life. So the woman who is malnutrition, mother is malnourished, the woman, babies are usually low birth weight, and they carry on that problems in the childhood as well. Breastfeeding, exclusive breastfeeding reduces the infant mortality and also helps in child spacing. We need to advocate that. And as I said, malnutrition, it starts from intrauterine life. If the mother is anemic, then she will have babies like this. And thank you very much. मुझे बार-बार कह रहा है टाइम खत्म.
Thank you very much. The next talk we have is Professor Dr. Ehsan Noman. He is Professor of Neurology, Dean Faculty of Neurology, College of Physician and Surgeon, Pakistan. His topic of talk is Evolution in the Treatment of Epilepsy, Journey from Shoe Sniffing to High-Tech Gadgets.
Assalamu alaikum. Thoda sa unchi awaaz, please. Thank you very much. First of all, it's really from my heart I'm saying, whenever I came to Sindh, I feel it's my second home. And I'm very much impressed by the hospitality and care of the people of the Sindh. Please. So, it's my obsession to show this slide in all my presentations. Despite having there are a lot of issues with this country, believe you me, still it is the best part of the world. It's my mission statement, neurology for all. Wherever needed, I will be available for neurology services. It's me on the slide. And I'm really extend my special compliments to the organizer of this superb event. I'm really impressed by the organizers, and my special love for my brother, Professor Dr. Manzoor Lakher, who invited me here to speak something that is very beautiful. And I am personally obliged and thankful to Gates Pharma for all the logistics they offered me with the love and care, and thank you very much. Have you ever been there? It's the northern area, or part of our beautiful country. It's the road to Babu Sar Pass. And my talk is a journey from shoe sniffing to high-tech gadgets like vagus nerve stimulation in the management of epilepsy. So, why I choose this topic? This is a very interesting story. Whenever I try to talk on shoe sniffing, I usually feel some sort of embarrassment from my seniors and my other colleagues. What you talking? It's a rubbish. Okay, no problem. It was my PhD who gave me some wisdom so I can talk, I can say something on this very old thought. And digging out this issue, believe you me, it gave me so many excitements. I can say very comfortably, either it's a shoe sniffing or it's a vagal stimulation, there's not big differences. It took about few years, believe you me. Exactly, it took about 5.5 years to answer this quest. And I'm just going to share very briefly about from my research diary. So, I need you people to raise your hands. Just be sincere. How many of you believe in shoe sniffing or aromatherapy as a part of the epilepsy? Only one, two, three, okay. And how many of you believe in this vagal nerve stimulation? It's a very high-tech gadgets, very expensive. Okay, it's made my talk very simple. Two from vagal nerve stimulation, two from VNS, or shoe sniffing. I will discuss it later. So if you talk about epilepsy, believe you me, it is the oldest disease of the mankind. Oldest. 2000, second millennium, the first report dates back to the Syrian text, and where they labeled it as a divine punishment or possession of some forces. And what they used at that time, about in the second millennium, the fumes of some herbs and chemicals at that time. And as still we are in 2022, and the same school of thought and same mode of treatment is still practicable in our part of the world and some other parts. So it is about 3,500 ago, the same practice still applicable in this part of the world. So who is this? It's a Hippocrates. He was a man who got a lot of contribution for this. He's the father of medicine and father of aromatherapy. And after 1,500 years, what he called, just listen please. What he said, he labeled epilepsy as brain disorder about 460 BCE. And he said, at that time, all the cases are of hereditary in nature. And the main thing is, very interestingly, at that time, what he claimed that epilepsy is curable and has a cure. And he tried his best to remove the divine origin. And believe you me, if I'm talking about 460 BCE, or no, I'm standing here and this 2022, and we are saying that the same thing, either epilepsy is a brain disorder and it can be cured. I just want to add just two things. What he practiced, he used to give herbs that are replaced by the medicines, and he used to give a very special diet in the patients with epilepsy. And as I mentioned, he's a father of aromatherapy. He used so many chemicals and herbs to treat not only epilepsy and a lot of other things. So it is basically, so you can appreciate, the khussa is a shoe that is the usually people do it. So you can compare it. Either it's a 460 BCE or it's a 18th or 19th century. There's no much difference. Surgery was also available at that time in the time of Hippocrates, or herbs are available. They are replaced in the 18th century by medicines, and special diet is also available. That is in 19th century. So there's no much difference. Either you're talking about just recently in 2022 or in 19th century, or if you're talking about the second millennium of the mankind. So I will just touch very briefly. Hippocrates was a very intelligent person. Believe you me, what he said? He mentioned that cause of epilepsy is something, a bad mucus in the brain. And he mentioned very clearly. And he offered that craniotomy of the opposite side of the scissor can be a curable measure for the epilepsy. And believe you me, from the history, craniotomy has been performed in the days of the Hippocrates, and usually it was the trephinations and blood letting. They are the usual methods used to just on the concept that epilepsy is because of some bad mucus or thick mucus in the brain. And if you talk about surgery in 18th century, it started just as cerebral abscess was operated as the cause of the epilepsy in 1831. I will a bit fast just for the sake of time. And then in 1886, a post-traumatic cortical scar surgery was performed as a cause of epilepsy. So just go in detail. The clozotomy was performed in 1934 in 19th century. Temporal lobectomy was 1950, A4 is just missing, and stereotactic surgery was performed in 1957. So there are main thing, the advancement is MRI, PET scan, SPECT, and so spectroscopy, and gamma knife is nowadays is a major concern. So you can say the thoughts of different surgical procedures, they're basically from the very old thoughts of the craniotomy in the terms of surgical procedures. So if you talk about medicine, they're long list, but I will concentrate just to remember only one thing. bromide in 1857. Just remember this thing, because bromide has a connection with the shoe sniffing. So bromide is usually found on the soils. So it is a postulated hypothesis that with the combination of the bromide in the soil and the shoe, they are the leather, they have some organic reaction and they have certain fumes and they can be called as anti-epileptic fumes. So this is the theory, basically, hypothesis. So there's a long list of things, 1912, phenobarbital, and you can go down. Valproate was introduced in 1967, and clobazam by 1970. So the short of time, I'm just giving you some in detail. From 1857 till now, we have these things. But before this era, 18th century, there was the herbs. They are being used for all these purposes. So this is basically, before 18th century, it was the herbs, and in 18th and 19th century, they're the replaced by the medicines. So if you talk about diet, the diets, some sort of special diet has been used by Hippocrates, and in 1911, the ketogenic diet has been introduced, and still the people that refractory epilepsy, they're using the same diet. So if you talk about something, the connection, I told you that the shoe sniffing, this has some reaction with bromide and gives some fumes that act like a bromide. That's the first anti-epileptic medicine. So it's just a work in process. I hopefully next year I will give the full detail of my study about this. So it is in 1988 when this vagal nerve stimulation was introduced and approved by FDA in 1997. And in 2018, the DBS has also been approved as a part of treatment. So then other responsive nerve stimulations, and believe you me, there are 4 other things that are futuristic strategies for to make the epilepsy curable with some stimulation processes. It's a continuous stimulation of seizure onset that is called subthreshold stimulation. Then we have minimally invasive surgery. Then we have TMS, and this is important, and this is supportive for my theory, that is the external trigeminal nerve stimulation. So वो जो खुस्सा है, सुंगाई है, that is basically, it activates trigeminal. So that is उसमें. So I'm sure that I still believe that not all of you will be believe in shoe sniffing, but scientifically, both procedures, if you talk about shoe sniffing, either it's the olfactory or trigeminal nerve is there, it is stimulation. But it is a crude method of stimulation, but that's the same thing, the stimulation we are using, vagal stimulation, DBS, the same stimulation method is there. So take-home thoughts are very simple. The concept of high-tech gadgets derived from very many centuries-old thoughts. And the new era is the stimulatory gadgets, so you can offer so many things for the treatment of epilepsy in the form of gadgets. Shoe sniffing is also stimulatory. It stimulates the either olfactory or vagus, trigeminal nerve. And finally, the concept of shoe sniffing will be shared soon with scientific justification, I hope within 6 or 7 months. And thank you very much.
Thank you very much, sir. The next speaker I would like to invite is Professor Dr. Iqbal Khayani, Professor of ENT and Head of Department of ENT, Head and Neck Surgery, Shaheed Mohtarma Benazir Bhutto Medical College, Liari General Hospital, Karachi. The topic is significance of prevention and early detection of oral cancers. I would request Professor Iqbal to please come up on the stage.
Next, previous.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizer for inviting me here as a guest speaker.
My today's topic is significance of prevention and early detection in oral cancer. And I am Professor Iqbal Khayani. And the purpose and the background of my presentation is that oral cancer is the sixth most frequent malignancy all over the globe. And 1/3 of the burden of oral cancer comes from South Asian countries like Pakistan, India, Bangladesh, Sri Lanka, because of the prevalence of usage of pan, gutka, chalia, and tobacco chewing. Significant number are preceded by pre-malignant lesions. Oral cancer is at rise in our population, especially in our province of Sindh. And alarming numbers are documented in younger adults recently. It is the second most common tumor in both the genders in our region. And the risk factors for oral cancer in our region are betel nut and chewing smokeless tobacco like pan, gutka, chalia, mawa, manpuri. Nutritional deficiencies and poor orodental hygiene can contribute a bit to the development of the oral cancer. But in the West, it is the alcohol usage and human papillomavirus, which is acquired due to perverted sexual practices in the West, is the main culprit in causation of oral cancer. So this is our problem. The pan, gutka, chalias are sold freely on the shops, which needs to be checked. Pathogenesis involves genetic and epigenetic events, which is ranging from normal mucosa to hyperplasia to dysplasia to carcinoma in situ to frank invasive carcinoma. And the significance of problem is that mortality and morbidity does not improve despite improvement in diagnostic and therapeutic strategies. It remained at 50 to 55%. The key factor of poor prognosis is delayed diagnosis. Patient present at the advanced stage due to socio-psychological reasons and fear of being biopsied and fear of being therapeutic intervention, leading to reluctance in seeking medical advice. This is our problem. See, the patient comes at this advanced stage, and it is very difficult to remove the disease completely with clear margins and to reconstruct the big defect. Already the patient is nutritionally weak, so there are more chances of complications of the disease. So, importance of early diagnosis cannot be stressed upon much. It improves patient survival. It has got less morbidity and mortality. It reduces the cost of treatment and the management, and better quality of life can be achieved, as discussed at length by Professor Yazdani and Professor Iqbal. Screening can be performed in the high-risk population who are using pan, gutka, chalia, and tobaccos. The diagnostic dilemma in general population is that if there is rat patch in the oral cavity, they don't think that it is a cancer. But if there are some lump or something, they perceive it as a cancer. So they go and consult unqualified local practitioners or quacks, because there is no proper referral infrastructure in our society, in our country. Sometimes trismus is a problem which poses difficulty in examination of the oral cavity to diagnose the disease. Our dilemma is that whenever we see the patient and advise biopsy, they are fear of being biopsied because of the misconception that after biopsy or after touching the steel or some metal thing, the cancer will spread. Alternatively, their friends and relatives give them advices and misguide them not to go for operation or biopsy. So they consult some alternative healers like Hakim, homeopath, and spiritual healer for Namdrud and everything. And they are also afraid of the complication and the disfigurement due to some surgical treatment of the lesion. trained professional and the auxiliary workers are, need to be trained, which are still in paucity in our society, and economic constraints, because the patient going for treatment of the oral cancer is very costly. So some people cannot afford it, and they are reluctant to seek medical advice for their problem. A new concept of oral self-examination for early detection has been introduced, in which the aim of which is that patient needs to know more about the clinical appearance of the oral cancer. Oral mouth examination may be used as an effective tool for awareness of the oral cancer and early detection, especially in high-risk population. So these are the 8-step oral cancer screening, oral self-examination, which we have devised, and we have done the trial in the camps, in which patients stand in front of the mirror with very adequate light, take 2 wooden spatula or spoons or gloves finger to examine the oral cavity systematically, especially if the patient is using or indulge in risk factor habit. That examine the upper lip, the upper gingiva, the cheek, buccal mucosa, the lower lip, the hard palate, soft palate area, floor of the mouth, and ventral surface of the tongue, and lateral surface of the tongue. These are the 8 steps to do oral self-examination for detecting or consulting any early change in the oral cavity. It is akin to the breast self-examination, which strategy is employed for early detection of the breast cancer in women. So we say that beware of your mouth and look for the signs and symptoms of the mouth cancer. Like, the most importantly are ulcer which do not heal within 3 weeks of its appearance, first appearance. If there is any red and white patch in the mouth, if there is lump or swelling in the oral cavity, if you are in doubt, and especially when you are involved in the risk factor habit, you should consult a professional, trained professional for diagnosis and treatment. These are the pre-malignant lesions which are essentially clinical diagnosis, and up to 90% can be converted to oral squamous cell carcinoma. These are leukoplakia, we all know that, the oral submucosal fibrosis, erythroplakia, and lichen planus. These are the main pre-malignant lesions which are potential in converting to oral cancer. So the diagnostic strategy is the same. We take a detailed history, including the history of the addiction and the involvement using of the risk factor habit, examination with mirror and palpation especially, and we can additionally use vital staining, spectrometry, cytology, or histopathology, or biomarkers, and imaging like plain radiology or OPG, computer tomographic scan, like MRI, positron, PET scan, and other ultrasound or something if required. So diagnosis of the pre-malignant lesion is essentially a clinical diagnosis. Systematic examination of the oral cavity with adequate illumination and 2 tongue depressors should be done. Biopsy is usually not taken in case of pre-malignant lesion because the patient is also reluctant to be biopsied in non-malignant lesion. Sometimes the trismus pose problem in examination of the oral cavity, so diagnosis would be difficult in some areas, in some people. Diagnosis of the oral squamous cell carcinoma, which are frank, is the same. Systematic examination of the oral cavity with adequate illumination and 2 spatulae, steel spatula. Site, size, and nature of the lesion should be recorded, and palpation should be done for the firmness and submucosal extension of the disease. Again, the trismus pose problem in examination, and biopsy should be taken for histopathology. So this is the frank oral squamous cell carcinoma. Site incidences are a bit different than the West. In the West, it is the tongue, which is more common, and in our region it is in the bucco-gingival sulcus, which is habit related because the people keep pan gudka chalia in the buccal sulcus, so they develop the oral cancer at that site. And 95%, over 95% are squamous cell carcinoma. As there is the patient is reluctant to taking the biopsy, but biopsy for histopathology is still and it will remain as a gold standard for diagnosis of oral cancer, which is a must before advising any treatment. But in the West and in other countries, there is paradigm shift from histopathology to molecular method of disease diagnosis. Sensitive and specific biomarker from scraping, rinses, brush biopsies, tissue blocks, and body fluids like saliva are utilized for diagnosis or early diagnosis of the oral cancer and pre-malignant lesions. Biomarkers serve as early footprints of the disease so that they can indicate that you might be having or may develop the oral cancer. So panel of biomarker can be detected by utilizing the nanotechnologies. Because invasive nature of the punch biopsy and blood collection is very disturbing and distressing for the patient, and there is reluctance, disagreement of the patient due to socio-psychological reasons. Saliva is a perfect biofluid. Natural ultrafiltrate of the serum reflects physiological and disease states. It's a body mirror. It is non-invasive, easy to procure, safe to handle, and effective, cost-effective. Large volume can be acquired, and wide spectrum of biological analytical information for clinical diagnosis can be done from that. So it is an efficient and perfect diagnostic medium. There is no patient anxiety and discomfort. DNA yield quality is good. It's a very effective tool for people in the high-risk population for screening. So we did two studies on salivary detection of biomarkers. We detected human papilloma virus 16 and 18 in the saliva of the patient with pre-malignant lesion and oral squamous cell carcinoma and in the controls. And we found that HPV 16 and HPV 18 were found in 20% of the patient with pre-malignant and malignant lesion of oral cavity, which is quite high. It clearly indicates that probably we are also following the West in the acquisition of human papilloma virus, as we do follow the West in all other things. Similarly, interleukin 6 and interleukin 8 were detected by ELISA in the saliva, and the good news is that the IL-6, that is the pro-cytokine, which are pro-oncogenic or promote formation of the cancer, is in 13.3% cases, and IL-8, which was found in 65.7% of the cases, which is anti-oncogenic, causes or it checks the spread of the disease. That is the reason why we don't have neck nodes even in advanced stages of the oral cancer. So this is one of the points that our population has got more level of IL-8, that is 65.7%. So our recommendation is that training of the healthcare providers, clinician, family physician, dentist, and healthcare worker to be aware of the risk factor, diagnosis, and importance of early detection of both oral pre-malignant and malignant lesion of the oral cavity is must. Awareness of the general public regarding balanced diet, oral hygiene, avoidance of the risk factor habit like pan gutka chalia, and practice of the safe and clean sexual relationship with the spouse. Public motivated for early diagnosis and told about disadvantage of delayed diagnosis. Public awareness program and lectures complemented by audiovisual ads, banners, posters, flyers should be organized. Print and electronic media should take initiative to educate the masses regarding the prevention to reduce burden of the disease on the society. We strongly recommend formulating legislation and strict implementation regarding ban on selling cigarette, areca nut, betel nut, pan, gudka, chalia, and other chewable tobacco products, especially to underage and younger individual. Strategic planning and policy making with provision of government funding to back the saliva-based research in context of rapidly growing use of nanotechnology for salivary diagnosis over the globe is a highly desirable goal in our etiologically distinct population. We took an initiative to organize public awareness camp in Badin in collaboration with Department of ENT and Head and Neck Surgery of LUMHS, Liaquat University of Medical and Health Sciences. Professor Mushtaq Mehman and his team was with us, and we came from Karachi all the way to Badin, and we organized a walk, a lecture, and a camp for testing our 8-step oral self-examination pro forma, so that we can contribute a bit in the prevention and early detection and give the awareness to the masses. But due to COVID, we could not continue it. And now, inshallah, as the COVID has been settled, we're going to organize more and more camps in the areas where there is oral cancer is prevalent because of risk factor involvement of gudka, pan, chalia, and tobacco chewing. So thank you very much. Once again, thank you for inviting me as a guest speaker. Thanks to the organizer.
Thank you, sir. The next speaker we have is Professor Dr. Khwaja Mujtaba Qadri. Professor Khwaja Mujtaba Qadri is a consultant nephrologist and chair Research and Clinical Investigation Center, Maroof International Hospital, Islamabad. His title of talk is Research, Innovation and Entrepreneurship in Healthcare, a Pathway Towards Achieving Key SDGs. So.
Assalamu alaikum, bismillahir rahmanir rahim, rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. I know I'm here between you and lunch, but I'm going to try and stimulate you into thinking that this is a topic that is as important as all the other topics before you, and unless you are in the research, innovation and entrepreneurship mode, you will be left behind in the circuitry of research and development worldwide. And I'll try and take you through some examples in the COVID era where we rose to the challenge as a nation as well. So respected panelists, chairs, faculty, students, whoever is here at this time, just want to take you through this particular pathway where we are going to be linking a couple of sustainable development goals with research, entrepreneurship, and commercialization. So just to remind ourselves, SDG 3 as part of the 17 Sustainable Development Goals talks about healthy lives and promoting well-being, and SDG 9 talks about industry, innovation, and infrastructure process development in order to have sustainable development. So we'll try and relate our talk to both these aspects. So in 2013, WHO had talked about transformative scaling of health professions education. It's not just about learning anatomy, physiology, biochemistry, and the like. It's important to have products as part of our health education system who will increase the quality and relevance of the kind of healthcare that we are trying to provide. And it's important to make a difference to the country's health outcomes rather than simply adding to numbers. So even in 2007, the Planning Commission had talked about service delivery as only being one end of the spectrum. It's so important that we need to translate ourselves, our work, into a knowledge economy. Are we living in interesting times? As the Chinese proverb says, obviously, we went through this Wuhan and beyond epidemic, and it's still there, and we are still talking about over 641 million cases, confirmed cases of COVID, including 6.6 million deaths so far, and there are several doses of vaccines have been given, 12.9 billion, but we all know which parts of the world have overused and abused that particular boosters, and which part of the world has not had even a single set of completed vaccines. So we talk about inequity in Pakistan, we talk about inequity worldwide as well. So just to take you through this translational spectrum, we talk about research going from basic science to humans, to patients, to practice, and to community, and that's where you eventually make a difference. So we talk about all these cycles taking about 10 to 15 years before a new molecule is taken all the way and goes through extensive testing in animal models, and then subsequently comes out into human trials and it becomes a drug. However, in the COVID era, we squeezed this cycle, and those who were at the cutting edge of research managed to overcome that by developing the vaccines for their population, and those who were at the back end of research, like our populations, that I'm going to show, see how far we fell behind. So in this article in 2009 in the New England Journal of Medicine, they talk about the fact that it's not anything else. It's just the barrier to performing high-quality research is capacity building, just an understanding of how research is done and implementing it and understanding the ethical rules behind doing research, which is the problem with developing nations in catching up with developed countries. If you simply look at Pakistan and Malaysia combination, so Malaysia is a country which has 1/8 the population of Pakistan, and if you look at the regional healthcare indicators, Pakistan is right at the top amongst these countries for all the wrong reasons. So we have the worst infant mortality, the worst maternal mortality, the worst under 5 mortality, the lowest life expectancy, and there's nothing to be proud of in this. When we look at registered clinical trials, again, Malaysia is 1/8 our size, and see what we've done in terms of clinical trials that is registered on clinicaltrials.gov. Even 2/3 of our studies are not even any phases applicable. So we don't know how to do research, and we talk about research and development. Whereas United Kingdom, whose cricket team is here, and I met some of those guys in the corridor today, I was excited. So they are about 1/3 or less than us, and they have this number of trials compared to what Pakistan does. So we are nowhere, and we need to make a difference. And I'm talking to the few medical students and residents out here that, because I've given up on my generation, but you are the ones that I'm speaking to today. This is the World Intellectual Property Organization statistics and data for what we've done in terms of filing of patents and commercializing them. So I don't know how to use this particular marker, but I'll just go across. If you look at this particular area, this is how we have commercialized our patents. So we have continued to file more and more patents, but we have not commercialized them. We are scared of making money for our country. And then so we'll be nowhere. So we continue to file patents. We don't know how to commercialize it. We don't know how to sell a product. And we call ourselves a proud nation. This is the triple helix which universities need to be doing. Universities need to be sitting as seats of learning to create knowledge, and they talk with industry and the government to produce solutions which are indigenous for our own problems. And this is the innovation cycle we need to go through. Research, innovation disclosure, assessment, intellectual property filing, then marketing, licensing, and commercialization, which eventually should lead to revenue generation. This is a snakes and ladders kind of a story, even for medical devices. If you are not careful, if you don't know the entire pathway, you're going to keep dropping down at different levels. But if you go through the entire pathway of innovation, disclosure, and then go through marketing strategy, eventually you'll have a product which is a licensed product, and you can sell it and you can export it. That's what Pakistan needs. The Drug Regulatory Authority of Pakistan has all the rules for you. It's there on the website for whether it is for drugs or whether it is for devices, and you simply need to get into the habit of understanding that research is not a luxury, it's a necessity. The patent laws are very much there, clearly stated. You can go to the websites and look at them. So things are there, the rules are there, the regulations are there, but we are still not shaking ourselves into doing research which is meaningful. So you could have a typical schematic where you have industry, academia, patent application and technology transfer, and then once you have that, then you invite these venture capitalists, the startup companies, to come and invest in your product. You sell it to them. It's important for us to come up with indigenous solutions in our healthcare problems that we have. So in COVID-19, Pakistan, thank God we did not become like New York or some other countries where there were bodies and bodies all over the place. But there was a need that if we needed ventilators of the extent that everybody else, what would we do? So people came and shaped up, and there were some locally produced solutions, and there were 7 different types of ventilators which were essentially some form of ventilators. Okay, they may not be entirely quality controlled, but there were some solutions which were suggested at that particular time, which obviously made us feel a little better about where we stand. I'm a nephrologist, so I have to mention that one of the US-based companies has set up an entire market in Lahore and they have US citizens and scientists come in here and who are employed by a Pakistani entrepreneur, a young graduate from LUMHS, who's employing them to come here and make this peritoneal dialysis cyclers in Pakistan. So that's one project which is an exciting project in our field as well. Capacity building and clinical research, my team has been involved in different institutions in Pakistan, whether it was at Shifa or National University of Medical Sciences or Maroof, in trying to build capacity at different levels, including at the COMSTEC level for OIC countries, and we are happy to do those things. Currently, I'm fortunate enough to be appointed the research chair for Pakistan, for the Pakistan Society of Nephrology Task Force for Research, and this is what we are concentrating on again, building capacity to research, enabling people to understand research and its rules and regulations. So this is some of the stuff we used to do at different forms of workshops. This logic model, it's in academic medicine, March 2010, if anyone wants to look at it. But basically, iska ek hi wo tarjuma hai ki jitna gud daloge, utna hi meetha hoga. So you have your infrastructure, you have your trainings, you have your research methodology workshops, you have your scientists all working together, and then you're going to have outputs in terms of increasing trainee satisfaction, supervisor satisfaction, and meaningful research, not just dissertations. Those dissertations that we come out with, nobody looks at them worldwide. They don't make it to the top journals. So if we are going to be a nation which is a so-called nuclear nation, say 5th most populous, 6th most populous, we love talking about numbers, but what's the quality of our output in healthcare? 0. 0 times 0 is 0. Actually, the patent score for Pakistan is 0. That's what I heard 2 years ago in a conference. I don't know what it is right now. Maybe it's 0.1 or minus. I don't know. So relating back to SDG Goal 3, in order to ensure healthy lives, research, innovation, and entrepreneurship in healthcare is essential. This needs to be operationalized as the model of triple helix between academia, industry, and government, and we need to provide local solutions to our local problems. Our citizens deserve better. In terms of the infrastructure, SDG 9, it is imperative that healthcare workers or professionals or trainees basically they have opportunities for internship in industry, the pharmaceutical industry, the laboratory industry, the diagnostic industry. Understand their needs. The scientists need to understand that, and we need to come up with solutions that we can sell, license and sell and export. This is our legacy. So we talk about James Lind doing these randomized controlled trials for patients with scurvy using vitamin C and all that. But way before that, Al-Razi and Ibn Sina talked about the rules of experimentation a century ago, but 1,000 years ago, but we've been sleeping since. I'd like to tone down and give you a little bit of food for thought. I mean, before I conclude, obviously I want to thank the Liaquat University of Medical and Health Sciences, Jamshoro, for inviting us. I'd like to thank Maroof International Hospital, where I practice my nephrology and also do research or research capacity building. I'd like to thank Board of Governors of Indus University of Health Sciences, whom I represent as part of the Board of Governors. But primarily, I'm here to basically thank you for all your attention, and I want to stimulate you into doing something. Are there any students here, first year, second year, third year, fourth year, final year students? No. Any resident here? Okay. So the first resident who comes up to the stage is going to get a little bit of a copy of my small book. It's called Discover the Ibn Sina Within. So who can race up to the stage? Oh no, you have to race up. I'm not going to count. You just have to come up and get it from me. Okay, this lady has led from the front. So she's going to discover the epilepsy now within, and don't give up. You know, the ladies are ahead of us, we know, but just come. There's another copy for you, and one for your dean. So thank you very much for your attention.
Myself, I'm a PG.
And see, there he is. And there's your copy. And I have one for your dean. Please make sure you pass it on to the dean. I'd like to thank my... Sir, are you the dean?
Yes, sir. Sir, he is actually double dean.
Double dean, sir.
Yes, sir. So there you go. Thank you, man.
So more than welcome. And I'd like to thank CCL Pharmaceuticals for making my stay comfortable, and my dear friend, Professor Puran Kumar, without whom I would not be here. He is the one who invited me and convinced me to come here to Sindhi Dharti, and this is what I love. Thank you so much. I belong to the same province as you people. I live in Islamabad. That's it. Thank you.
Thank you. Thank you very much, sir. And a special thank you for the gifts. The last speaker we have is Professor Dr. Maimoona Siddiqui. Professor Maimoona Siddiqui is Professor of Neurology, currently working at Shifa College of Medicine, and she is the Program Director of Neurology Residency Program. The topic is Women Issues in Neurology. Madam, please come up on the stage.
Okay, Assalamu alaikum everyone. सबसे खुशी की बात ये होती है लास्ट स्पीकर की कि इसके बाद खाना है. तो I wouldn't take long. First of all, thank you organizers and Professor Manzoor Lakhir for inviting me here. And मैं इस्लामाबाद से आई हूँ, लेकिन हैदराबाद is my second home, और आप ये कह सकते हैं कि first home, because my husband belongs here, और मैं हमेशा बहाना ढूंढती हूँ हैदराबाद आने का. So it's always a pleasure to come here, and today we will talk about women issues in neurological disorders, because women brain matters. इससे पहले we talked about, Dr. Essen talked about, give you some flavor about neurological disorders, especially epilepsy. Then we have a lecture on, talking about triple mortality, maternal mortality, which is still, it's not up to the mark. So what I'm going to talk about, what problems or what neurological disorders the women face, and how to, how we can tackle them. So we know that United Nations, these SDGs serve as a blueprint to achieve a better and more sustainable future for all, and especially the target 3.4 that states that the deaths from mortality from non-communicable diseases should be reduced to 1/3 by 2030 through prevention and treatment and promotion of mental health being and mental disorders. So when we talk about neurological disorders, these are the leading cause of disability and the second leading cause of death globally. And despite this high global burden, the access to both the services and support for these conditions is insufficient. We were talking yesterday, and Dr. Essen told me that BB Pakistan mein we are, there are 370 neurologists, trained neurologists in the whole country, and that translates around like one neurologist per million. So there are issue of health access to the neurologic, to the people who can consult neurology. We don't have posts in different hospitals at district levels for neurologists. And recently, in May 2022, the WHO formulated an intersectoral global action plan on epilepsy and other neurological disorders. That's main concern was to address the challenges and gaps in providing care and services for people with epilepsy and other neurological disorders. And they asked all the member countries to formulate plans, national action plans, so that they have care across all the sectors. So when we talk about women in Pakistan, they constitute about 48.5% of the population. And according to a recent survey, 15% of the women of reproductive age currently live with at least one type of disability. And as we also discussed earlier, the level of women health is among the lowest in the world, and it's also unfavorable as compared to if we compare it with other regional countries. And the access to healthcare, poverty, there are a lot of social, taboos and lack of awareness which contribute to the poor health status of women in Pakistan. And then the other factor is that women are usually underrepresented in most of the clinical trials. Pregnancy is an exclusion criteria. So, when we talk about evidence-based medicine, where comes the evidence? Usually from observational studies and registries. So the women neurology basically focuses on neurological disorders through a gender-based lens, and this encompasses care throughout a woman's life, including the reproductive health, pregnancy, and healthy aging. And they're not only the disorders which are more prevalent in women that we have to deal with, but also the disorders which are equal in both men and women, but they have specific concerns around pregnancy. So when we talked about neurological disorders, epilepsy, as Dr. Ehsan also mentioned, that it's one of the most common neurological disorder, and it is estimated that 70 million people live in this world have epilepsy, and approximately 15 million women with epilepsy are in reproductive age. It affects the men and women equally, but there are certain issues which are, unique for women, like, treatment during their adolescence, pregnancy, contraception, and menopause. So the specific considerations that we have to consider is what are the hormonal effects on epilepsy, how we are going to manage people with epilepsy during their pregnancy, what are the teratogenic effects of anti-epileptic drugs, and what are their relation with contraceptive methods, and what are their effects on bone health. So we know that the epilepsy the hormones have effect on epilepsy, and then, there are interactions with anti-epileptic drugs. Simply, we know that estrogen has a pro-convulsant effect, while progesterone increases the inhibition. So it is anti-convulsant. So one of the most real life example of the effect of hormones on epilepsy is catamenial epilepsy, which is reported to be as high as 70% of women, including young women. And basically, it's that their seizure frequency increases during the periods, or it exclusively occurs during the menstrual cycle. And there are three common patterns. Either they occur in the start of the menstrual cycle, or during evolution, like from day 10 to 14, or in females who have anovulatory cycles, then usually they occur in the second half of the cycle. So presently there is no FDA-approved treatment, but the options we have is progesterones, medroxyprogesterone combination supplements. There are studies that showed that clobazam can decreases the risk of seizures during periods, acetazolamide, and another option is that you increase the dose of anti-seizure medications that they are taking before their periods if they have a regular cycle. Then in pregnancy, the good thing that you have to counsel is that most of the women remain seizure-free in pregnancy, and generalized tonic-clonic seizures were seen only in 15% of the pregnancies. So the factors which are associated are if they have focal epilepsy, they are on multiple medications, or they have decreased anti-seizure medication levels, then that the risk of seizures increases during pregnancy. And the frequency before preconception, if their seizures are controlled before pregnancy, then the chances are that they remain seizure-free during the pregnancy also. The medications should be tailored according to their seizure type and their seizure frequency, and they should be given in the minimal effective dose. One of the important thing is that please avoid valproate during pregnancy or in women of reproductive age, because valproate is not only teratogenic, but it has a lot of side effects which we do not want our girls to have, like obesity, hirsutism, polycystic ovaries, infertility. And even there are studies that have shown that the newborns who are exposed to valproate during pregnancy have intellectual disabilities at 16 years of life. You have to give folic acid supplementation in patients, in women who are pregnant and have epilepsy, to reduce the risk of neural tube defects. So this graph shows the results of different main registries from Europe, from North America and UK, and if you see that, if it's working, the main teratogenic effects and side effects are noted with older antiepileptics, especially valproate, phenytoin, and in the newer drugs, topiramate is associated with cleft lip and palate. Newer medications like levetiracetam, lamotrigine have a better safety profile. So when we talk about contraception, it's always good to discuss it before it is needed, because most of the pregnancies are unplanned, and you sometimes need them to regulate their menstrual cycles and for PCOS. So if they are on a non-enzyme inducing AADs, you don't have to do dose adjustment, but if they are on enzyme inducing AADs, then the first choice is intrauterine devices or depot medroxyprogesterone. So if the management of epilepsy, if the patient should have a multidisciplinary team that consisting of a gynecologist, a neurologist. They should have regular antenatal follow-ups. If you want to adjust the doses or make some changes, please do it pre-conception. And you have to consider the teratogenic effects of different AADs used. So now coming to migraine, which is another condition common, one of the most common primary headache disorder, which is more common in women and interferes with their work, social life and family life. And सबसे बड़ा प्रॉब्लम ये है कि ख़वातीन को जब सर में दर्द होता है तो कोई उनकी अहमियत नहीं देता कि जी ये दर्द ऐसे ही हो रहा है, but you know migraine is very disabling. So if you consider So if we can see the effect of migraine on pregnancy, there is increased risk of gestational hypertension and preeclampsia, and there is increased risk of strokes and cerebral hemorrhages, especially if women have migraine with aura. That's why combined oral contraceptives are not recommended or contraindicated in patients who have migraine with aura, because they increases the risk of stroke. And we can consider also low-dose aspirin, especially in patients with migraine with aura. So the treatment recommendations are, you advise them, relaxation techniques, biofeedbacks, and the medicines, paracetamol or metoclopramide are readily safe. You can use NSAIDs before third trimester, and there are a lot of studies that now shows that triptan's data is safe, but still they are not recommended by FDA. So the red flags that you have to consider are if the patient had a new onset headache or there is a change in the character of an existing headache, you have to consider other diagnosis. If they have a thunderclap headache, you have to rule out subarachnoid hemorrhage. If there is high blood pressure, preeclampsia or eclampsia is associated with that. If they have visual loss, seizures along with headache, then you have to consider or rule out cerebral venous thrombosis, Press syndrome, and any other focal neurological signs that will point to a secondary headache disorder or any other thing underlying secondary disease. So coming to stroke, stroke is also the leading cause of death worldwide, and it's more common in females. And not only that they are more frequent, but the outcome is also poor, and they have poor quality of life after stroke. And they are less likely to receive thrombolytic therapy, and this is the Western data. And the factors that are associated with poor outcome are if they have pre-stroke function that's low, if they have a large stroke, obesity, and if they are nursing home residents. And there are certain risk factors which are specific for women that increases the risk for stroke, that's pregnancy, oral contraceptions, hormone replacement therapy, migraine with aura, obesity, and metabolic syndromes. So now coming to the neuroinflammatory disorders, these are autoimmune disorders. As you know that these are usually more common in women. And the neurological these disorders include multiple sclerosis, neuromyelitis optica, myasthenia, and autoimmune encephalitis. So multiple sclerosis is an autoimmune demyelinating disease. It's considered to be rare in this part of the world, but with new, diagnostic imagings and available, we now know that it's not that uncommon. And usually it affects young women, and they have to face because it's a disabling disorder. They not only have to manage their issues regarding fertility, pregnancies, and menopause, but they also have to manage their disease. So it has been seen that the fertility is also affected, and the prevalence of sexual dysfunction is estimated to be 40% among women. There is no overall detrimental effect of pregnancy on MS. However, there is increased risk of relapse postpartum. And the most important predictive factors are what are their relapse rate before pregnancy. If they had a relapse during pregnancy, then they have increased risk of another relapse. If they have a more disability at the time of pregnancy and the long duration of illness. Usually they have a normal, uncomplicated pregnancies. The medications, usually they should be individualized. And they have to consider pregnancy if they are in remission, they have a favorable, stable disease, and they should be given folic acid and vitamin D supplementations in case of deficiency. So if you look into the therapies, these are the disease-modifying therapies like interferon and glutamate is considered to be safe as a disease-modifying therapy. Ocrelizumab, you have to wait for at least 1 to 3 months before conceiving. Rest of the medications are mainly contraindicated. Neuromyelitis optica is another inflammatory autoimmune disease which is associated with astrocyte dysfunction and secondary demyelination. And it's associated with aquaporin 4 antibodies, and this is also more common in women. The relapse rate increases during the 3rd trimester and postpartum, and the factors again are maternal age, if they have any other comorbid condition, and what medications they are on. There are reported cases of increased spontaneous abortions, miscarriages, and preeclampsia in patients with NMOSD, and they need, a multidisciplinary approach. So the medications that are usually safe are high-dose methylprednisolone that we can give if they have a relapse during pregnancy, azathioprine and rituximab. And there are new medications now available for NMOSD, but their data is still lacking, but eculizumab is considered to be safe. Now coming to the neuromuscular disorder, myasthenia gravis is an autoimmune neuromuscular disorder in which there are autoantibodies against the acetylcholine receptors mainly, and then there are other receptors also. And it has a bimodal presentation, and it's more frequent in women up to 50 years of age. And the pregnancies in patients with myasthenia should be considered high risk, and they need, a multidisciplinary approach. The second stage of labor, they need assistance, especially if they had a recent exacerbation or they are in myasthenic crisis, because myasthenic crisis can occur in 6.4% of the pregnancies, and this can be life-threatening. So you have to, plan before pregnancy. You have to stabilize the disease if they are planning for. And the chances of disease exacerbation is around 30%. There is a risk of neonatal myasthenia, so you have to monitor the baby for the symptoms. And maybe if the symptoms are more, they need, sometimes short trial of paradystigmine. We know that thymectomy is one of the definitive treatment, and if it improves the outcome, and if you are planning for thymectomy, you have to do it before pregnancy. Finally, autoimmune encephalitis. These are a group of encephalitis in which the most common is anti-NDA. And these antibodies, they affect the brain. Usually the patient presents with psychiatric symptoms, seizures, and loss of consciousness. Mostly affects young women, and usually it is associated with ovarian teratoma. But if even it's not associated with ovarian teratoma, it's more common in women. The other type of encephalitis are relatively rare, but most of them are more common in women, and usually they show good response to steroids and other disease immunosuppressive therapies. Finally, the neurodegenerative disorders, dementia. Dementia is more common in women, and not only it's more common, but its affect more severe. It's more severe also, and it's more difficult for women to have access to adequate care. And not only this, that they are more affected by dementia. In 2/3 of the cases, the women are the caregivers for the people of dementia, and it has seen in a lot of studies that they get less support if, as compared to their male counterparts, if they are a caregiver, and there's more burnout and exhaustion in these women. So the take-home message is that WHO has prioritized brain health through these IGPA goals over the next decade, and many neurological disorders have important gender concerns. And thorough knowledge of these disease that affects women is important, so to provide them good care. So the important factors that we have to consider is what are the hormonal effects, the effect of medications, and the effect of pregnancy on the disorder, as well as the converse. So for them, multidisciplinary approach is needed, and we need, pregnancy registries in our country so that we had our own data and we can have our own guidelines, so how to manage these disorders during the whole reproductive and in menopause. Thank you.
Thank you, madam. This brings us to the conclusion of the plenary talks. And now, as a tradition of Liaquat University of Medical Health Sciences, we would like to commemorate our speakers and the panelists. And to award the shields, I would like to request our worthy panelist to please come forward on the stage. Professor Sattar Sahab, please. Dr. Asif Berni, Subhanova Sahab, please come on the stage. Thank you. I would request Professor Dr. S.N. Naman to please come up on the stage and receive the shield and certificate from Professor Sattar Memon. Next, I would like to request Professor Dr. Maimuna Siddiqui to please come up on the stage and receive her shield and certificate from Professor Asif Berni. I would now request Professor Dr. Khwaja Mujtaba Sahab to please come up on the stage and receive a shield from Professor Ashok Kumar Narsani. I would request Professor Dr. Iqbal Khayani to please come up on the stage and receive his shield and certificate from Professor Dr. Feroz Ali Kalhodo. The next is Professor Dr. Azizun Nisa. Professor Azizun Nisa, is she in the hall? Okay. To honor our panelists, I would request the worthy deans of the Liaquat University, Professor Ashok, Professor Munawwar Alam Ansari, and Professor Feroz, to present the shield and certificate to Dr. Abdul Sattar Memon Saab. I would request the worthy deans to kindly present shield and certificate to Professor Asif Berni Saab. And now I would request Professor Sattar Memon and Professor Asif Berni Saab to please present the shield to Dr. Munawwar Alam Ansari. Oops. I would now request to present the shield to Professor Feroz Ali Kalhodo. I would request Professor Sattar Memon Saab to please present the shield to Dr. Ashok Kumar Narsani. Thank you, ladies and gentlemen, for your presence here today. This brings us to the conclusion of first plenary session. I hope you have enjoyed it a lot, and you are now requested to proceed for the academic council hall upstairs at first floor for lunch. Thank you.